Good evening, friends. Good evening, friends. Warm welcome to the PG Clinics. Today we have two important cases. The retroperitoneal tumor. The other one is the mass abdomen. Retroperitoneal tumor case is contributed by Professor Haridas from Government Medical College, Mysore. And mass abdomen is kindly contributed by Professor Shanai sir from Kasturba Medical College. We have the most eminent faculty, Professor Anurag Srivastav, joining from AIMS, New Delhi. Professor Pavnindalal sir, joining from Maulana Azad Medical College. And we have our eminent faculty, Panna sir, Shanai sir, Srinivasan sir, Hitesh Andaria sir, Rajiv Sakai sir, Karnakaran sir, and Srinivasan sir. So we'll have the candidate, Dr. Sushant Shandilia. Can you try sharing your PowerPoint and start your presentation, please? Dr. Sushant?
Yes, sir.
Good luck to you. All the best. Faculty, please take over.
Sushant.
Anurag sir and
Sushant, can you?
Sir.
Is this the slideshow?
Yes, sir.
Okay. Yeah. Okay, that's good.
Good luck, Dr. Sushant.
Yes, sir. Good evening, faculty. I am. Is my slide visible?
Yes,
yes. You can proceed.
Good evening, faculty. This is Dr. Sushant Chandilia, second year junior resident from Kasturba Medical College, Manipal. I am presenting the case of mass abdomen. My guide is Dr. Rajgopal Shinai sir, and my head of the department is Dr. Dinesh sir. I am presenting a 54-year-old female homemaker by occupation from Malpe, Udupi, Karnataka. She is a morbidly obese female with a weight of 135 kg, diabetic and hypertensive since 2 years, who presented with complaints of pain abdomen since 5 months and mass abdomen since 4 months. History of presenting illness. Patient was symptomatically normal 5 months back when she noticed pain in the left upper quadrant of the abdomen, which was insidious in onset, dull aching in nature, mild to moderate in intensity, continuous type, and progressive in nature. It was relieved on analgesics. There was no relation of the pain with food intake. There was no radiation of the pain to the back or the retrosternal region. About the mass, she also noticed a mass in left upper side of the abdomen, which was insidious in onset, gradually progressive in nature, and attained the current size in a span of 4 months. Initially, she says that 2 months back it was as big as the size of her own fist. However, in the span of recent 2 months, it grew into a size of 10 into 15 centimeter in size, involving almost all the parts of the abdomen according to the patient. There is no history of fever. There is no history of any hematemesis, bleeding per rectum, melena or dark stool. There is no history of any altered bowel or bladder habit. There is no history of jaundice. There is no history of any weight loss or loss of appetite or early satiety. There is no history of any breathlessness or cough. Past history. She's a known case of diagnosed case of fibroid uterus since 20 years. There is a history of fistulectomy done 8 years ago. She's a known case of and hypertensive since 2 years on medications. In family history, there is no significant family history. Personal history, she consumes a mixed diet. There is no history of any substance abuse, normal bowel bladder habits, no sleep disturbance. Menstrual history, she attained menopause at the age of 50. RT3 and 3 live births and no history of any abortion. Summarizing my history, morbidly obese, hypertensive and diabetic lady with pain abdomen since 5 months and mass abdomen with 4 months of duration, with no history of any organ or system involvement. It's rapidly enlarging mass abdomen.
Sushant.
Yes, sir.
So you have a 54-year-old lady with obesity, with a mass which is occupying the whole of the abdomen. What do you think you're dealing with? Most likely, no other symptoms, no pressure symptoms either. Are they? Could you go back to your first slide, please?
First slide, sir.
So this pain abdomen and mass in the
Yes,
abdomen.
sir. In the left side of the upper
Okay.
abdomen.
With nothing, with no other symptom. What
No
do you
other
think you're
organ
dealing with?
specific.
What do you think you're dealing with? What could be your
So
probable diagnosis?
Sir, with a rapid increase in the progression of the size of the mass, I'll think of any benign any tumors arising from retroperitoneum.
No, why are you hesitating with benign or malignant? What do you think it is? I mean, just say it. No harm. I mean,
Retroperitoneal tumor.
you're thinking of retroperitoneal tumor.
Yes, sir.
Are they very common? I mean, why do you think it's a retroperitoneal tumor?
Because there is no organ specific symptoms, sir, and it is very large. It has
Okay, so tell me an intraperitoneal tumor which is silent, grows into a large stuff like this.
liposarcoma, sir.
Liposarcoma, where?
Intraperitoneal.
I'm talking of intraperitoneal stuff.
So intraperitoneum.
Yeah,
Yes.
yeah. I mean, if a lady comes to me with such a large lump in last thing, strike to only think of.
In females, what are the things you would like to think? See, you know the diagnosis. This is different, but in general, a lady like this which comes, what probably that's what question.
So it started arising from the left upper abdomen. So
What swelling can happen in lady which can give rise to such a big swelling? That's the question the sir is asking. Lady.
any ovarian
Right.
Yes, yes.
So probably it could be an ovarian. You think it's a benign or a malignant stuff?
malignant, sir.
Why do you think it's malignant?
Sir,
Rapid growing.
is within 4 months. Sir.
Can this be inflammatory in origin? You should take the patient's
Sir,
start.
clinically there is no in history wise there is no history of any
Why?
fever.
There is pain. Started the whole problem started with pain.
Yes, sir. It started from the left upper quadrant. Sir.
Could you go to your next slide, please? Let's see your description of pain.
Yeah,
Yes.
pain. What is the description of pain?
It started in the left upper quadrant since 5 months ago.
Okay.
Serious onset, dull aching in nature, mild to
It's a
moderate.
dull, mild or mild to moderate pain. Maybe she may be taking some. So the pain is not very significant.
Yes, sir.
It's just there,
Yes, sir.
right? And anything else?
There
When you
is-
talk of retrosternal radiation,
yes, sir. There is no radiation
no. Why retrosternal? What did you think of when you asked this question that no retrosternal radiation? There must be a reason why you asked for this.
Large swelling abdomen and with the retrosternal radiation of pain. What is the idea of asking that?
This idea.
Carcinoma.
any mass arising from the stomach stromal tumors, sir, which erodes the mucosa, causes ulcerations
Oh, where? Ulceration where?
in the stomach lumen, sir.
How common is a gist?
It's not very common, sir.
Very rare. Stomach itself is very rare. Gist is just 1 or 2% of all gastric cancers. So what are
You have
the
radiation to pain in the back. What is the idea of that?
Any pancreatic tumor, sir, which by the time it starts presenting, patient comes with fixed mass or pain.
No, hang on. We are not dealing. Don't jump to the conclusion that it's malignant. What else can a a condition in pancreas produce this kind of a
Pancreatitis.
lump? Huh?
Chronic pancreatitis.
Chronic pancreatitis will produce this kind of a lump.
What swelling?
No, sir. The pseudocyst of pancreas.
So that's why I asked you initially, is it an inflammatory? You said no.
So now
Pseudocyst of pancreas arise from what? What condition can arise from? Pseudocyst is due to what? Pseudocyst is after what condition can develop a pseudocyst? You can
After any episode of acute pancreatitis.
pancreatitis, isn't it?
Yes, sir.
Pancreatitis. That's what I asked initially. Can it be inflammatory? Maybe, but pain is not very typical of pancreatitis. It's a very small, mild to moderate. You said.
Yes, sir.
Type. So that's not the pain you get in pancreatitis. What type of pain you get in pancreatitis?
Sharp,
severe pain.
Yes.
Radiating to the back.
Yeah, it's more severe pain you get. So it's a mild to moderate intensity, tolerable pain. It's not likely. Likely, I don't know. Maybe okay. So there
any
is
other any other causes of pseudocyst? What are the other causes of pseudocyst? One is acute.
Any blunt abdominal trauma, sir.
So did you ask for that history?
Yes, sir.
Let's go back. I didn't see it. That's why.
It's not mentioned in the slide here, sir.
That's right. So it's not mentioned. We don't accept it. Okay.
Yes.
You might have asked and kept it to yourself. So that's why I'm asking you. Okay.
Yes.
That's right.
I have one question for benefit of PGs, that in females, what other pancreatic thing can occur without even history of pancreatitis? Any large tumors in especially pancreas? Anything else?
Any lesion like cystadenoma, if female mucinous.
Yes.
What type of cystadenoma? What are the types of cystadenoma?
Mucinous cystadenoma, sir, in elderly female.
Can you get
Sir,
this?
we have, sorry to disturb you, sir. We have Professor Anurag joining us now. Welcome, Professor Anurag Srivastava.
Thank you, sir.
Please carry on, sir.
Good evening. Can I just ask this question? The student said that pain in pancreatic origin radiates to the back, but actual description is that it radiates through to the back. So there is a difference whether it goes to the back or through to the back. Through to the back means patient will put his or her finger in the epigastrium above the umbilicus, right? And then he or she will say that pain goes through to the back, means it goes directly to the back, right? Whereas any other pain, say gallbladder origin, it will go round to the back. So that is the difference. Pain goes through to the back, straight burrowing pain going straight through to the back. So that's the description, okay, of pain of pancreatic origin.
That is mainly because the infiltration of the nerve and inflammation happening in the retroperitoneum. That's why it goes through to the back. Okay.
And it is slightly relieved by bending forward. Stooping or bending forward, and increased when you extend the lumbar spine. Okay.
Going back to our cystadenomas, what are the other types? What is the age of this patient? Sorry, I forgot. What is
54-year-old, sir.
Okay. What is the age group you get? Commonly get mucinous cystadenoma.
Childbearing age group.
Sorry.
40 to 50, sir.
Yeah. 1+, please don't answer the questions.
Yeah, it's more in the, what is the classical description? What type of swellings are more common in daughters? What type of common swellings, cystadenomas are more common in mothers? Some type of cystadenomas are more common in grandmothers. So what type of swellings are, cystic swellings of pancreas are more common in daughters?
Sushant, if you don't know, say you don't know, okay?
Yeah.
And there is some phone with 1+ CPH 2381. Please mute and don't answer, okay? Yes, please go ahead.
The very young age group, that's daughters, we get something like Franz tumor, the pseudopapillary tumors, SPM, pseudopapillary tumor of pancreas. No, it's more commonly seen in very young ladies. The mucinous cystadenomas, as you described, is more commonly seen in mothers, 45, 50, that age. Okay.
Yes.
The third group of cystadenoma, serous cystadenoma, you get in grandmothers. Like it's very little more, 65, 70, that age group. Okay. So age-wise is like that. So sir was asking, what type of if it's a pancreatic cystic swelling, what it could be?
Mucinous cyst adenoma, sir.
Yeah. Which part of the pancreas is more commonly associated with mucinous cyst adenoma? Which part of pancreas?
Body.
Yes, more body and tail, isn't it? Body
Yes,
and tail.
body and tail.
Serous cyst adenoma?
Head.
Head, more of a head region. Okay.
Yes, sir.
More of head region. What is the peculiar feature of mucinous cyst adenoma?
Lobulated.
Radiological, what is the classical description?
Lobulated.
Okay, we will discuss it later. I think we will go ahead with the history. We have the history. When you discuss about the investigations, we will discuss about. So that's again a differential diagnosis of pancreatic cystic neoplasm. Okay,
Yes, sir.
mucinous cyst adenoma arising is again a possibility. So okay, right. So no history of other. So after this thing, history should be able to tell us what is the anatomical origin, what is the anatomical structure associated, and possibly what is the pathology. So what do you think they after history, hearing history, what is that? Practically, this is a large abdominal mass with no bowel or bladder or any other system involved, isn't it?
Yes.
So when you get such a system, about a mass with no other systems or complaints, what will you think about?
Sir, anatomical origin wise, initially I thought of any splenomegaly.
Splenomegaly.
Because it was the mass started from the left upper quadrant and now it developed towards the right lumbar, right iliac fossa.
Okay. Any other thing? Spleen maybe okay, maybe asymptomatic. Otherwise, agree. Anything else?
Yes,
so, because you are you're not.
I ruled out, sir. I ruled out any renal mass, which can be polycystic or gross hydronephrosis.
History, you can't say the renal polycystic. We are the history. We are analyzing the history. Patient doesn't have any renal symptoms or bowel symptoms, nothing. So, what are the possibilities such a large swelling in a lady?
Yes, sir. I initially I thought of any retroperitoneal mass.
Yes, definitely you need to think about retroperitoneum because a large mass without any symptoms. First, you definitely think about retroperitoneum. Yes. Anything else?
It can be a
mass. Retroperitoneal what mass?
liposarcoma.
Don't categorize retroperitoneal swelling. Maybe a soft tissue swelling in the retroperitoneum, isn't it? Okay. Yes. Then
any mass arising from the
arising from? No, I didn't hear you. Sorry.
Mass arising from ovaries.
Yes. So the classical teaching is whenever there's a large mass with no symptoms involved to any systems, think about the retroperitoneum, think about the ovaries, think about the uterus sometimes. Okay.
Yes, sir.
Anything retroperitoneum. So maybe soft tissue swelling, maybe a lymph nodular mass. Spleen is possible. Yes. Large spleen can also be otherwise asymptomatic. Okay. So these are the possibilities. Now, next question is it inflammatory? Is it neoplastic? If it is neoplastic, is it benign or malignant? Don't examine.
Progression within 4 months, sir. I suspected malignant towards more malignant, sir.
Why you think malignant?
Within 4 months, sir, it has grown.
Rapid progression. Rapid progression of
rapid progression.
Yes. Okay. So you think malignant? What type of malignancy it could be?
What type, sir?
Yeah, what malignancy? What malignancy from where?
Retroperitoneal, sir. Liposarcoma mostly.
Possibly large retroperitoneal sarcomas.
Or soft tissue sarcoma, yes, sir.
Okay. So it's even possible to have a pancreatic mucinous adenoma, as sir mentioned, which is mucinous cystic adenoma. Okay.
Yes, sir.
These are the things. So you are not considering an inflammatory swelling like a pseudocyst, no?
No, sir.
Yeah, because typically it's not a presentation of pseudocyst.
Yes, sir.
Okay, so you don't have to consider it's not a pain, it is not the progression of a pseudocyst. You get more severe pain or before the onset of the swelling, you expect a little more serious pain. The pain was mild according
to
okay.
And do you know very big tumor, but still it is benign of the ovarian? It's a very big tumor, but still benign ovarian tumor. Have you heard of the Meek syndrome?
I'm not sure of, sir.
Mixed syndrome is where the patient has the fibroma of the ovary. And they are very big tumor which are there, maybe associated with the pleural effusion, even with ascites. But still, they are the benign tumors which are there. Why did you ask histo dark stool? What is that dark stool?
Sir,
I know dark stool. What is that?
Melina, sir.
Oh, Melina, you have mentioned separately. Can you go to your back to your slide? Where there is. See, you have written bleeding PR, Melina, and dark stool.
Yes, sir.
So,
And the spelling of Melina is wrong. Spelling is MELAENA. You should correct the British English.
What is Melina, Sushant?
Upper GI bleeding, sir.
Only upper GI bleeding?
Sir, Tari altered blood passed in with the stool, sir, with foul smelling and sticky in nature.
Okay, can you get this bleeding in small bowel and maybe
Yes, sir.
fecal?
Yes, sir. We can get it till
yes. It is not only upper GI, it's described in standard textbooks. You can even get in cecal or bleeding, you can get it. So basically means is dark, as you mentioned, very dark, altered, sticky, foul smelling stool. Okay, so you can get it even in and proximal small or small.
yes, sir.
Okay, so dark stool also it's not it's unnecessary. You are inviting trouble by writing another dark stool. It's not necessary. Maybe what do you mean by dark stool? Maybe the patient's taking some drugs which is producing dark stool. Is that what you mean? Just like that you wrote carelessly, is it?
No, sir.
Okay.
In history, how can you say the patient is morbid obese? You have written specifically in the summary, morbid obese patient.
Yes, sir.
So on history, how can you say that the patient is morbid obese?
Yes, sir. After general physical examination, I measured the weight and height, sir.
Yeah. So after the BMI only, you can say the patient is morbid. But not on the history. You may say the patient is obese, looking obese. But to say morbid obese, you have to have some cutoff point for that.
Yes, sir.
Okay.
I'll go ahead with the general physical examination, sir.
Yeah, go on the examination.
Patient was conscious, oriented to time, place, and person, and cooperative. Weight was 135 kg and height was 160 centimeter. BMI was around 52. Pallor was present. There was no icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Vitals, pulse was 74 beats per minute in right radial artery, regular rhythm, good volume, no arterial wall thickening. Blood pressure was 130 by 70 millimeter of mercury in right brachial artery in sitting position. Respiratory rate was 17 cycles per minute. Saturation was 98% on room air. Temperature was afebrile at the time of examination. Abdominal examination. On inspection, abdomen is grossly distended. A vague mass is seen in umbilical region, left lumbar region.
Hold on 1 second. Can you show the previous slide? Previous slide. So why did you mention that temperature febrile at time of examination? Do you want to say that blood pressure, respiratory rate, pulse, everything is up to date now? Only the temperature was at the time of examination. Why do you want to say that? Everything was at the time of examination only, no?
Yes, sir.
Yeah, why you want to specifically say temperature at the time of examination? Unnecessary. Okay, all these findings are only at the time of examination. You are not seeing the patient now. Okay.
Yes.
Why the GCS at this point? Why the GCS?
GCS also added. Why?
Is it a routine practice to write the GCS at this point?
No, sir.
In a case of abdominal lump?
Yeah, why you
unnecessary?
Unnecessary. Okay, don't invite trouble. There are no unnecessary things. Okay, try to avoid all this.
Yes. On inspection,
abdominal lymphadenopathy. What type of lymphadenopathy you look for in general examination? Where did you look for lymphadenopathy?
Cervical,
You
supraclavicular.
mentioned generalized lymphadenopathy. Okay, you are not looking for any specific group. Generalized lymphadenopathy, cervical, both cervical area, axillary. Suppose there is lymphadenopathy. What is the significance in this case? Suppose there's generalized lymphadenopathy, multiple nodes are there.
I can suspect lymphoma in such case.
Yes, retroperitoneal swelling, you can have multiple nodes, always can correlate, isn't it? Edema, yes. What type of edema you look for? Edema, you said you vaguely mentioned no edema. Where did you
because of the mass, gross, like this big mass can compress the veins.
Yes.
And might cause bilateral lower limb edema. Sir.
Yeah, you specify that. Okay, no edema means it's not okay. Bilateral, you can specifically say no bilateral pedal edema. Okay, so that means yes. No compressive. Not only that, you can any dilated veins in the abdominal wall. That also probably you can mention along with that you are excluding an IV compression. Okay.
Yes. Sir.
Such a large mass. Okay. So you can be a little more specific when you mention all these findings.
Yes. Sir.
Okay, carry on. Continue.
On inspection, abdomen is grossly distended. A vague mass is seen in umbilical region, left lumbar region and right lumbar region, which moves with respiration on inspection. Umbilicus is pushed downwards, inverted. There is no visible scar, no skin changes or engorged dilated veins, no visible pulsations, no visible peristalsis. There is no fullness noted at a renal angle in sitting position. There is no impulse at hernial orifices. This was the big mass which was palpable, which was on inspection, which was in left lumbar region, lower part of the left epigastrium, right lumbar region, very umbilical region from the side.
Okay.
On palpation,
from this
abdomen.
Where is the main bulk of the mass situated?
So on inspection, it looks like the main bulk is on the right side. Sir.
Right side, right lumbar, right.
Yes, sir. Reaching right iliac.
And it's crossing the midline?
Yes, sir. Continuous and yes, crossing the midline.
Okay. Right.
Abdomen is soft. There is no guarding or rigidity. A mass of size 30 into 20 centimeter is palpable in the left lumbar, umbilical, hypogastric, right lumbar, reaching right iliac fossa, extending from 5 centimeter below the subcostal margin on the right side to 3 centimeter above right ASIS. On the left side, it is from 4 centimeter below the subcostal margin to 6 centimeter above the ASIS.
Here again, like the main bulk of the mass, you already mentioned the right side. Now you started as describing the masses in the left lumbar umbilical like that. Okay, you can always start mentioning, describing from the maximum size where it is present. Like that, you can go to the opposite side. Main bulk is on the right side, which is extending to the left side. That is percentage. So you can present like that, rather than the other way around.
Upper and lower borders were well palpable. Surface was bosselated, borders were round, but on both the sides they were diffuse. It was firm in consistency all over the mass, crossing continuous in the midline. There was also restricted side-to-side mobility present. Mass becomes less prominent on leg raising test. There is no other mass palpable in the abdomen. No swelling palpable in bilateral renal angle, supraclavicular region. All hernial sites were normal on palpation. Per rectal and per vaginal examination were normal.
Is it bimanually palpable?
No, sir.
You didn't mention about it. Is it important to look for bimanual palpation?
Yes, sir. Bimanual is. I checked, sir, bimanual, but I have not mentioned it here, sir, because it was a one single mass occupying both the lumbar regions.
So why you didn't mention? What is the reason you didn't mention?
I was not suspecting it from renal.
Oh, bimanual palpation only you get in renal swelling?
A large retroperitoneal mass can also be.
Yes, anything occupying the lumbar region and lumbar region will be bimanually palpable. You are talking about ballotability. What is ballotability?
When we put our left hand under the if we are examining on the right side, left hand under the abdomen and right hand above the on the anterior abdominal wall. We palpate the mass and then we push the mass from our left hand and we see if it hits on our right hand. Sir.
Okay. So ballotability is usually associated with which structure?
Renal, sir.
Why is it more commonly mainly seen in renal only, not in retroperitoneal sarcomas?
Due to the perinephric fat pads. Sir.
Okay, perinephric fat gives a space for it to move. Not only that, it's pedicle. No, the renal pedicle will allow the renal mass to move. The retroperitoneal mass is more of tightly packed in the retroperitoneum. No space for it to move, and there is no pedicle as well. It could be bimanually palpable, definitely, but not ballotable. Okay, so you have to mention in a lumbar region mass whether bimanually palpable. That indicates only this mass is largely occupying that region only. Okay.
Yes.
Both sides it could be bimanually palpable because it's extending to both lumbar region according.
Yes. Yes.
So that's a very important finding as well. Okay. You mentioned about any free fluid in the abdomen?
There is no free fluid, sir. On percussion, sir.
Okay.
On percussion, dull note over the mass, all over the mass, except a band of resonance across the mass. Other than the mass, the abdomen was tympanic to percuss. Liver span was noted around 15 cm clavicular line. There was no free fluid noted. On auscultation, normal bowel sounds were heard. There was no bruit over the mass. Respiratory system examination, bilateral normal vesicular breath sounds were present. There was no added sounds. On cardiovascular systemic examination, the S1 and S2 were heard. There were no murmurs, no added sounds. Central nervous system was examined. Higher mental functions were intact. And
Hello.
Summarizing my history and examination. Morbidly obese, hypertensive and diabetic lady with plain abdomen since 5 months and mass abdomen with 4 months of duration. With no history of any organ specific or system involvement, with rapidly enlarging mass abdomen, a 13 to 2 centimeter mass, bossulated surface with restricted transverse mobility, occupying almost 5 regions of the abdomen.
Sushant, is this tumor intraperitoneal or retroperitoneal? I mean, you've not distinguished between the two as yet.
Yes, sir.
Is it important to know whether it's intraperitoneal or retroperitoneal?
Yes, sir. On clinically, till clinical examination, I was unable to differentiate it between
Why can't you differentiate? Such a large number, you can't differentiate.
I was unable to put the patient in knee elbow position.
No, you don't have to put the patient in knee elbow position. Is there any other way of doing it?
Left lateral
shift? Yeah, shift test. What is shift test?
Can you put the patient in any other position to check?
Lateral decubitus.
And what will happen?
If the mass falls forward, it is abdominal mass or intra-abdominal mass, intraperitoneal. And if it forward,
you've not done that?
I have done, sir. I was unable to differentiate.
So have you written it anywhere that you've not been able to differentiate? Because look, the whole premise of your case rests on whether it's an intraperitoneal or retroperitoneal mass, isn't it? You made a diagnosis of retroperitoneal, I'm sure, isn't it? So how have you come to that conclusion if you can't differentiate it from intraperitoneal or retroperitoneal? Your whole examination falls apart if you don't have this fact with you, isn't it?
Yes, sir.
Okay.
Also, did you mention anything about the transmitted pulsations, anything like that?
Yes, there was no visible pulsations.
No, not visible, palpable.
Let's go back to your look.
On palpation, was there any transmitted pulsation?
No, sir.
Okay, just go back. Just go back. You said that mass crossing the midline. Now, which masses cross the midline and which don't?
Clinic mass crosses the midline, sir.
What? Okay. Any other
mass?
Any other mass? Can you distinguish between an adrenal mass and a renal mass?
Sorry, sir.
I mean, very simple.
Can Shalini, I think I'm saying that please mute. Please mute.
I didn't hear you, sir.
No, he asked basically which mass crosses the midline, which all masses doesn't cross.
Which are the masses, right? Which are the masses cross the midline, which don't?
Splenic mass crosses the midline.
You said that. We heard that. Any other mass?
Liver mass crosses the midline, sir.
I mean, we're talking of organs which are right on each side.
No,
Splenic is also on one side. We are talking of organs which are on both the sides.
Yes, not liver.
Pancreatic mass crosses the midline, sir.
Not at this time. Which are the organs which are present bilaterally?
Kidney, sir.
Right. So does kidney mass cross the midline or not?
It can cross the midline, sir.
Okay. What about adrenals? Okay. Suppose this was a child. How will you distinguish between a neuroblastoma and a nephroblastoma? Crossing the midline. Okay.
Only cross the midline. So here it is crossing the midline, isn't it?
Yes, sir.
So which type of swelling can cross your midline which fits into your diagnosis?
Any retroperitoneal mass, sir?
Yes.
Or any intra-abdominal mass also, which is arising from mesentery, or any soft tissue mass.
Yeah.
What about liver? What about hepatic mass? Liver mass.
Hepatic mass also will
involving both lobes.
Both the lobes, yes.
He mentioned about that.
Because the diagram you have shown, it looks as if there is enlargement or diffuse hepatomegaly. You know.
Yes, sir.
This looks like a diffuse hepatomegaly. You know, at least from the diagram.
Why is it not considering the liver, according to you? Very basic question.
So it was far away from the subcostal margin bilaterally.
Okay.
The upper border.
And you could feel the upper border.
Yes, sir. Yes, sir. I could feel the upper border and lower border separately, sir.
Okay.
You are saying it's involving the hypogastrium, but your picture doesn't show that it is.
This marking is on the basis of inspection, sir. However, palpation, this marking which I have made is on the basis of inspection.
So palpation is coming more.
On palpation, it is involving periumbilical and hypogastric region, sir.
You to show that marking, not this marking, is it?
Yes. Yeah.
Exact marking. Okay, what swellings can happen? Okay, retroperitoneal swelling is acceptable. Any other intraperitoneal, as somebody sir asked in the beginning of your presentation, any intraperitoneal mass can present such a large swelling? I think already discussed in the beginning of the history.
Yes, sir.
Now you said the patient has a fibroid of the uterus and your PV examination is normal. Do they go together? And you gave the history that the patient had a fibroid of the uterus.
There is a fibroid uterus, yes, sir, since 20 years.
And PV examination normal?
If it was normal.
No, the question is, can it be normal?
It can be, sir.
Yes. In which situation?
Which is submucous.
Subserosal fibroid.
Subserosal fibroid.
Yeah, cavity. PV may be normal also. Okay.
Yes.
Yeah. So you have to substantiate. Sometimes the questions are in such a way that you have to substantiate your finding. You have to stand.
How will you differentiate between a fibroid of the uterus and the ovarian tumor on PV examination? How will you differentiate between a fibroid of the uterus and an ovarian tumor on PV examination? You do the bimanual examination.
Yes, this ovarian mass will be bimanually palpable.
No. Ovarian mass will not move on movement of the cervix. So you have to move the cervix.
Yes.
If the mass moves with the cervix, it is a fibroid.
Yes.
If the mass doesn't move with the cervix, then it is probably the ovarian. Okay.
Yes.
Can this be a large gist arising from posterior aspect of stomach?
Yes, sir. It can be, sir.
So, what will be the presentation of a gist?
Mass in the abdomen, sir.
Yeah. A large cyst in the retrogastric area. Can exactly, but it's too big to be. It's extending lower down. Can it extend to such a hypogastrium and all? It's very unusual, isn't it?
Yes, sir.
Extending right up to the hypogastrium. So acceptable. I think your first diagnosis is the one we stand, the retroperitoneal soft tissue swelling. Agree. There's no, I don't think, in many situations, there is no need for many differential diagnoses. Okay. Many times it is always acceptable to have one differential diagnosis and stick to that, one diagnosis. Yes, so soft tissue sarcoma is acceptable for me. So fine. Gist, okay. Rarely post retrogastric gist, but such a big gist extending right up the hypogastric is very rare. What other lymph node posterior retroperitoneal swellings like what are the other retroperitoneal swellings we can get apart from soft tissue swellings?
Sir, pancreatic pseudocyst or pancreatic mass.
Yeah.
Adenoma, mucinous adenoma can grow to a larger extent, sir.
So Sushant, can you again tell what are the big causes of big lumps in the abdomen? Big lumps of 30 centimeter size in the abdomen.
It can be renal mass, sir.
Okay.
It can be splenomegaly, sir.
Okay.
Hepatomegaly.
Okay, if it's a retroperitoneal sarcoma, what is the type of other swellings? Can it be lymph nodular mass? Other retroperitoneal swellings are usually lymph nodular mass. Can it be lymph nodular mass?
So lymph nodal mass 30 centimeters, sir.
Yeah, that's what I'm asking. Can it be?
No, sir.
Size is nothing against it. Are these swellings in an area of lymph nodes? All these swellings are in the area of lymph nodes.
Bilateral in the lumbar region, sir. So I didn't suspect it, sir.
Yes, that's what. It's not in anatomical position of lymph node.
Yes.
That's fine. The size is not a problem. Maybe
Yes.
sometimes you can get large swelling.
Can it be a hydrated cyst? Have you seen big lumps arising in the hydrated?
Yes, sir.
Big lumps arising in the Cox abdomen, encysted ascites.
Yes, sir.
So these are the other causes for
Yes,
the big. So in the female, first with the ovarian.
Yes, sir.
Okay, and then the other lumps are there.
Can you push this mass into the pelvis? When you examine, can you push this mass?
No, sir.
Is it
No,
going
sir.
to the pelvis?
No, sir. There is the only mobility which is there is in the transverse plane, sir, which that is also restricted, sir.
Usually, ovarian mass,
Sorry, sir.
may not go into the pelvis, but it can be slightly pushed into the pelvis sometimes. Okay, because usually it arises from the pelvis. It may be able, but large mass may not fit into the pelvis. That's the only thing. But here there is absolutely, and main bulk is above the umbilicus, isn't it? The umbilicus, lumbar region, and extending into the hypogastrium. So that's one thing maybe against ovary, but size is always a concern. Large size always consider ovary and rule it out. Okay. Fine. So your first diagnosis, soft tissue, benign or malignant swelling?
Sir, I was expecting malignancy because rapid progression.
Okay, what is the most common benign malignant retroperitoneal swelling?
Liposarcoma.
Can you name other sarcomas arise from the retroperitoneal? Common swellings. I agree. Liposarcoma is the most common. Agree, no doubt. Leiomyosarcoma.
Yes, sir. Leiomyosarcoma.
Malignant peripheral nerve sheath tumor.
Yes, sir. Ganglioma, schwannoma.
Malignant. All these are included as malignant peripheral nerve sheath tumors.
Yes, sir. Yes, sir.
Okay. From where does it arise? This liposarcoma. What is the origin of the lipocytes? Where is the fat situated?
Sir, later on investigation wise, sir.
No. Pathology. I'm asking about pathology. What is the origin of the fat from which where is it originating from? Hypocytes. It's perinephric fat. No, a lot of fat is there. It can arise from the perinephric fat, and we can extend it. So liposarcomas generally they can extend to the whole abdomen. It can extend huge size and can extend to the whole abdomen. It can present like this without any other symptoms. No other symptoms are there. You can right. So did you examine the lower limb? We want to know one of the differential diagnosis malignant peripheral nerve sheath tumor, isn't it?
Yes.
Are you saying anything about the lower limb, neurovascular status, the vascularity, dilated veins, edema, physical status? Are you interested in now, at least now, to go back and see all this?
I had examined, sir, when I was doing a general physical examination.
No, it's not in general physical examination. You have to specifically look for the neurological status, isn't it?
Yes.
Nerve sheath tumors can arise from any nerves in that matter. Okay, can even have the. So here again, the peripheral, even it could be having a problem incontinence sometimes with large tumor. It depends from which nerve it's arising from. Okay, correct examination, maybe laxity of the sphincter. Now at least go back and do all this. Okay.
Yes.
Okay, lower limb weakness. Any nerve can be involved. So motor, sensory, autonomic, any nerves can be involved. All the somebody's phone is, somebody's.
I think everyone should be muted.
Can everyone mute please? Lot of disturbance here.
Dr. Kanavila will have to do something about it. The whole fish market here today.
Now only he can help. Kanagavil sir can only help us.
Aurelia.
Rajgopal sir, how many people can you ask?
Yeah, Aurelia is now muted.
Lakshman Prasad, Galaxy 832. Lakshman Prasad, please mute yourself.
Where is our Sushant is gone?
I am here, sir.
Yeah. Okay. So now these are the things. Okay, you have to at least go back and see. These are common retroperitoneal sarcomas arising from common liposarcoma, but malignant.
Lakshman Prasad sir, please mute sir. Lakshman Prasad sir, please mute sir.
Hello, good evening.
Yes sir. Yeah. So
good evening, Shanai.
Good evening, sir. Good evening, sir. Sushant, I would like to also add for the benefit, large mass question has been asked. Since it is a solid one, we thought of solid, but sometimes one of the differential diagnosis for a large mass is sometimes cystic swellings, which includes large retroperitoneal cyst, which is usually a lymphatic cyst, just like a mesenteric cyst. They can also attain a large size, but more so in children, young children. Unilateral hydronephrosis, or for that matter, idiopathic hydronephrosis, bilateral large polycystic kidney. All these come into the large masses for this. Sir, we can continue, I think. We can continue.
Yes. So these are the differential diagnoses we have. Now, how do you proceed?
So we got an ultrasound abdomen pelvis done, sir, which was showing a 35 into 37 centimeter heterogeneous echoic lesions arising, which was suspicious of arising from the mesentery on ultrasound, sir.
Okay.
And there was no free fluid. And meanwhile, sir, we got done the. Sorry, sir.
Is the ultrasound a good investigation in this case, or adequate investigation?
Like the first invest we got done was ultrasound only, said to know the anatomical location of the anatomical location of the mass and whether it is solid or cystic, the ecogenicity.
Fine, no problem. Yeah, what next? So you can always do ultrasound is easily available, no problem. Absolutely, you have to do that.
Yes. Meanwhile, we got done routine blood. The patient was diabetic, so we started the patient on extra insulin, sir.
Okay.
And we got CCT abdomen pelvis done, sir. Liver, in stomach, duodenum, small bowel. Here we'll see the mass arising in the right side and then in the left side with a connection in between, with a feeding vessel of superior mesenteric artery and a fibroid uterus. So these were the lobulate mass on the right side and on the left side in the axial scan, and feeding vessel from superior mesenteric artery. It was a heterogeneous and major. Most of the mass was fat attenuated, and bowel loops were pushed to the posterior and inferior, and fat planes were maintained with the anterior abdominal wall and bowel wall.
So what does it look like in a CT scan?
It looks like intraperitoneal mass.
Because its feeding vessel is from superior mesenteric.
Yes.
What is
And
CT?
On the coronal section, this is the scan, and sagittal section. So the official report of the CT was an intraperitoneous mass with predominant fat attenuation with two intralesional soft tissue components and septated, stranded, and occupying lumbar, right iliac fossa, periumbilical, hypogastric, left lumbar region. Size of around 32 into 17 into 17 centimeters. Well, loops were pushed posteriorly and towards the left and inferior, with maintained fat planes with the bowel and anterior abdominal wall of no infiltration, and there was a superior mesenteric artery feeding branch. No mild free fluids are adjacent to the lesion, suggestive of malignant etiology, likely liposarcoma. They suggested an HPE correlation, no lymphadenopathy, calcified uterine fibroid was noted, no significant lung or mediastinal abnormality.
Okay, few questions. How do they differentiate malignant etiology from CT scan? With CT scan, what are the findings which suggest it's a malignant?
Yes, the heterogeneous in nature, and liposarcoma, they see for the contrast opacification, more contrast enhancement more than the fat, and
the main features are the size, large size, more than 10 centimeters considered as possibly malignant. Possibly malignant.
Irregular.
Then you mentioned about septae. Septae was thick septae, more than 2 millimeter, I think the size, more than thick septae in between, and heterogeneous nature. Fatty, other than fatty tissue present inside tissues differentiated from benign lipoma to malignant liposarcoma. Okay.
Yes.
These are so that's why they probably think it's a malignant etiology. Yes. What is the most common radiological evaluation you do in a suspected soft tissue sarcoma? In limb, for example, a limb soft tissue sarcoma. What is
MRI?
MRI. Why you went for CT scan in this case? Agree, it's a choice. CT scan is a choice in retroperitoneal or intra-abdominal soft tissue sarcoma. What is the reason? The reason is, when you do MRI, the motion artifacts will be more exaggerated in MRI. Okay, that's one. The gas interface will be better. Bowel gas interface will be better evaluated with CT. And always, even if you do in the peripheral soft tissue sarcoma, if you do MRI, for the evaluation of its metastasis, you need a CCT, chest, abdomen, and pelvis. So might as well, you can complete the same investigation with CT. in the abdomen, chest, and one go we can finish the entire study. See, these are the three reasons why which retroperitoneal soft tissue sarcoma always the preferred investigation is CCT. Okay, so you can assess the primary lesion. Apart from the lesion, now what are the other things you need to look for in this case?
Any vascular invasion, sir?
Yes.
Any lymph nodes?
Which vessels specifically mentioned? Which are the vessels you would like to look for?
Superior mesenteric artery, iliacs.
Clinically, now you have to evaluate from clinical point of view. So mass was extending both lumbar region,
Yes, iliac.
Iliac vessels. Yes, correct.
Yes.
Yes. Anything else? Any other structure you would like to evaluate with CCT?
IVC, sir.
Okay. What about the ureters, the kidney?
Yes, sir. Yes, sir. Yes, sir. Kidney and ureters also, sir.
Yes.
Sometimes they compress and back pressure hydronephrosis happens.
Yeah, sometimes the entire kidney ureter will be encased in the tumor. You won't be able to split. So what is the significance of that? Suppose one kidney is encased, so you can see. What suppose the kidney is encased, one kidney.
So in total, we'll have to remove. Sir.
Yeah, you might remove, so you have to assess the opposite function
yes,
of the
yes,
kidney.
Yes, sir.
So
yes,
these are all the opposite kidney is functioning, the ureter is okay, all these things you have to evaluate by CT. Okay. So the iliac vessels, the kidneys, the ureters. In this case, already there is a branch supplied by the superior mesenteric artery.
Yes.
The superior mesenteric artery itself is encased in this tumor. It's a very important thing also. Okay.
Yes, sir.
All these makes this tumor maybe partially resectable or not at all.
Yes, sir.
Okay. There comes the role of ultrasound. Now I'm going back to ultrasound.
Yes, sir.
So now you tell me, is ultrasound be the only investigation in some cases? Can you completely avoid a CCT in some cases?
Small.
No, suppose you find an ultrasound, an extensive lesion, which is with liver metastasis.
Yes, sir.
Do you need
if it's already metastatic, sir, which if it
do you need a CCT at all?
The liver mets.
Yes. Can you avoid CCT in such situation?
Yes, sir.
You don't need because already the metastatic disease. What is
palliative? We can start palliative.
Okay. Probably we can still do it, but CCT is still an expensive evaluation in many centers, like a government setup and also costly evaluation. So probably no need because already metastatic disease, you can go ahead with other definitive histopathology evaluation. So don't avoid an ultrasound. Ultrasound is a very important evaluation. In all intra-abdominal malignancies like this, carcinoma stomach, colon, if you ultrasound can pick up the liver metastasis in the carcinoma stomach, it's an inoperable lesion, isn't it? Otherwise, you don't need a CCT at all. So we did that. So they suggested don't lymphadenopathy, calcium, all these tests. So possibly liposarcoma, right?
Yes.
What further evaluation? How will you?
Yes,
anybody can come in, sir. Anybody? Can I or others can add? Want to come in here?
We went ahead with image-guided, USC-guided core needle biopsy, sir, for this.
Why you won't went for core needle biopsy in this case? Is it acceptable to have core needle biopsy? What is
it's not mandatory, sir.
Suppose CCT, is it showing any signs of inoperability in this case?
No, sir.
So is it necessary to have core needle biopsy in such situation? What is the protocol of retroperitoneal?
Yes, sir. For a core needle biopsy, if there is a doubtful inoperability, or if we are suspecting lymphoma.
Yeah. Or germ cell tumor or metastatic tumor, then only core needle preoperative biopsy, isn't it? Here, it looks like more of an operable, isn't it?
Yes, it was not mandatory.
So, what is the problem? Why you don't want to do a core needle biopsy if it's operable?
Seeding can happen, sir, if it is.
Yes. Only in very specific cases, you need a core needle preoperative biopsy. Okay. Otherwise, what you do is exploration can remove the tumor.
Yes.
Because otherwise, the moment you break the capsule of the tumor, it is a metastatic. Okay.
Yes.
So ideally, no need for a biopsy. If it is radiologically, you feel it is a operable lesion, you can always go for us straight away the resection or the exploration and try to remove the tumor. Okay.
Yes.
So how what will be your incision in this case? How it's supposed
yes, midline laparotomy incision, sir.
Okay.
So long midline laparotomy incision we kept. First we counseled the patient for exploratory laparotomy, and we went with a large midline exploratory laparotomy, and we resected the mass in toto. With, there was a intra findings. So after opening the abdomen, there was a 35 to 30 centimeter mass arising from the mesentery. Around 30 centimeter of the jejunal loop was adherent to the mass, which was dusky. The tumor was not infiltrating the superior mesenteric vessels or its main branches. The rest of the small bowel loops were pushed to the right lower quadrant and the pelvis. There were no signs of any liver metastasis, peritoneal metastasis, or any ascites. 2 separate nodules were noted in the greater omentum, which was excised and sent for biopsy separately.
There are some interesting images. Just go through because time is catching. After that,
Yes.
I request the examiners to ask some more questions. Yeah.
So when we opened the abdomen, and this is the greater omentum reflected, and this is the mass, including this, and here jejunal loop is there, which was adherent to the mass, which was dusky in color. These two were the soft enhancing soft lesions, lobulated lesions.
Is it arising from the wall of the jejunum?
No, sir.
Is it a gist arising from the jejunum?
Yes, sir.
Jejunum, is it arising? It looks like it's arising from the wall of the jejunum, isn't it?
No, sir.
No?
We have. I'll put another picture.
Okay.
So here we resected.
There was a lot of difficulty in separating this jejunal loop from this such a large mass. So yes, as you rightly put it, there was doubt, but immediately after that we went go ahead. Then we realized that it was not possible to save this jejunal loop. We tried make an attempt, but I think it was breaching through the pseudo capsule. Then that is the reason why we go ahead with the resection of the jejunum, even though it was looking initially, but it was not from the jejunum later. You can it was a little difficult on the depth because we are not able to see what is going into the depth here. Otherwise, the most of it could be mobilized as we come near the superior mesenteric cord at the base there, at the root. So that is the one area was little difficult. Slowly went ahead. Rest of the things came out, but as you see, this is a very nodular surface, and already capsule is also partly, it is rapidly growing here. And later we could be able to separate it from the leash of vessel from the superior mesenteric cord, few branches, and this is the specimen, and with that jejunum which is opened, I think the one.
Yes, sir. Yes, sir. Here we opened the jejunum, sir. So
we are able to get it out in toto without leaving any part of it. My worry was only at the depth. Otherwise, there was not much of no fluid, nothing. So inferior vena cava, everything was free. There are some technical issues. I have to tell that even though renal kidneys were not involved, we did DJ stenting here for the simple reason that what we sometimes because of this Ayushman and schemes, etc. Patient come at one time, and we operate sometime 3 to 4 weeks later. So it would have also grown by the time patient came. So CT scan was a little older one. So what I'm trying to tell is, to the benefit of the doubt, we did DJ stenting in this patient. Retrospectively, probably it was not required. Sir, now you can go ahead and ask him some questions. So technical issues.
So why Sushant, now can you tell us why the jejunum was removed in this case? Sir, removed the jejunum correctly.
Yes, sir. We tried dissecting between the mass and the jejunum, sir.
No, the reason is that they may be sharing the common vascularity, isn't it? So otherwise, they're sharing the common vascularity. That's why. Otherwise, wall was not involved. You can see this picture. They're sharing common vascularity. So we'll have to look. Otherwise, okay, that's correct procedure.
Yes. And later on, end-to-end.
Do you think it's a liposarcoma or something else?
Yes, sir.
Looking,
Yes, sir. Liposarcoma.
Looking like fatty swelling, isn't it?
Yes, sir.
Maybe okay. But this part maybe looking like a little bit just I don't know. this area, left side. Anyway, maybe. So look, so any other procedure you could have done before surgery. Suppose it's a very large swelling. Suppose it's infiltrating some
Yes, sir.
experience. You may
We could have started chemotherapy.
Chemotherapy. Okay. Any other procedure you can do? Chemotherapy or anything else? No. Chemotherapy is acceptable. Large swelling. So if it is technically infiltrating some structure, you are not able to take it out on upfront. You can always take a biopsy, but you need a biopsy for that.
Yes, sir. And in this case, sir, when we took the biopsy, so the sample came out as insufficient, and they said it's lipoma because it was variegated in consistency. So from wherever the corneal biopsy was taken, it was suggestive of lipoma. But we spoke to the pathologist. They said that the chances of liposarcoma cannot be ruled out.
What are the types of lipoma? Liposarcoma, sorry.
Liposarcoma can be well differentiated, poorly differentiated,
or de-differentiated.
Or de-differentiated.
Any other types?
Pleomorphic, round cell, and myxoid.
Okay, you already written. Okay.
I have some literature on the topic also, sir. At the end, side-to-side genostomy was done, sir. And post-operative period was uneventful, and patient was discharged on post-operative 11, sir.
I think we'll stop at this juncture. We'll ask some other panelists to ask some questions. That is because there is one more case to be discussed. Sir, Anurag Srivastav, sir, Khanna, sir, if you have any other questions or any other faculty, please, related to the.
Right.
What is the further plan in this patient?
Sir, it came as well-differentiated liposarcoma, grade 1, sir. So we discussed it on our tumor board, sir, and they said there is no need of any adjuvant chemotherapy or radiotherapy, sir. So, and margins were clear, sir. So, R0 resection. So, we discharged the patient, and now we want to follow up the patient, sir.
How will you follow up this patient? How will you follow up this patient?
3 months and then 6 monthly, sir, for the first year, and yearly.
How will you follow it?
USG will get them. Ultrasound abdomen.
You know, ultrasound has got a very important role in any abdominal lump which is there. Okay, I think probably after your inspection, palpation, percussion, or auscultation comes ultrasound. Any lump. So that at least gives you the guideline that what further you are going to do. Okay, so ultrasound remains as a very important investigations even for the follow-up. So at every stage, the ultrasound is very important.
Yes, sir.
Any tumor marker for this liposarcoma?
Yes, sir. S100 and MDM2, sir.
Okay, so you have done that?
Yes, sir. It was done. It was positive, sir.
That's positive for that. Okay. Thank you.
Did you describe the presence of or absence of lymph node in the left supraclavicular region?
Yes, sir.
Any lymph node in left supraclavicular region?
No, sir. There was no lymph nodes.
Okay. So, right. So, in which tumors or in which conditions you get enlargement? Which abdominal conditions?
Tumors arising from pancreas, liver, stomach, colon, and in a male patient, testis.
What is the most common site of metastasis?
Suppose patient has melanoma. Suppose patient has melanoma of the foot. Will that tumor eventually cause enlargement of left supraclavicular node or not?
Yes, sir.
So in fact, they said that any tumor below the diaphragm,
tumor, because
any condition below the diaphragm, it is drained by thoracic duct, and it may carry the lymph node. So what is the type of spread, which is the term? There's a pathological term for involvement of left supraclavicular nodes. It is called retrograde lymphatic spread. Retrograde lymphatic spread, right? So if you cut a lymph node of the supraclavicular fossa, which is involved by abdominal malignancy or even melanoma from the foot or any below the diaphragm, it will have tumor cells in the center, right? Because it is coming in a retrograde manner from the efferent lymphatic. Efferent lymphatic enters the hilum of the lymph node, right?
Yes.
If you see the structure of a lymph node, the efferent enters through the hilum, right? Where there is fatty hilum. So the tumor will be seen, at least in early stages, in the center. And the cortex and outer capsule will be normal. Whereas if you have antegrade lymphatic spread, like in, say, breast cancer or stomach cancer, where primary tumor goes to the lymphatics, then to the afferent, through the afferent lymphatic, it enters the subcapsular sinus, right? Capsule, just below the capsule, and then goes to the outer cortex. From cortex, it enters the medulla, and then the deep cortex or paracortex. So paracortex or deep cortex is last to be involved in antegrade spread. But in retrograde lymphatic spread, such as abdominal malignancy spreading through the thoracic duct, the hilum or the center is the first to be spread. So retrograde lymphatic spread, that's the term.
Yes.
And what is the name of the lymph node? Eponym?
Virtuous.
And the sign is called?
Rosier's sign.
Right.
So can we wind up? If
Sure.
Yeah, we have a similar case setting next. So we'll wind up when this.
Please.
Thank you, sir.
Thank you.
Well done.
Nicely done, Sushant.
Nicely discussed and presented. Yeah. Very good.
Sushant, if you have any question, please ask. That is what Dr. Karanka will always encourages.
Always give you the opportunity to ask it.
Nothing much, sir.
Because this is one of the common cases for MS postgraduate examination. So a large mass in the abdomen has rightly been pointed out. Female means yes, ovary to come first, and not to miss pregnancy, sir. I have to tell you, admit one patient came with a almost up to the above the umbilicus and a large mass. I made a diagnosis of a uterine mass, but patient is very clear that patient has undergone tubectomy, the early part of this one. So his patient comes to OPD, and a postgraduate told me, sir, mesenteric cyst or something is there. Young patient actually, already 24, 25-year-old, tubectomy has been undergone. So something, he said, something I am feeling. Actually, I was able to feel the fetal parts, in fact. So later, yes, recanalization. So what these things do happen. So female patient, keep it in mind that solid tumors like retroperitoneal, mesenteric mass, nodular mass, lymph node, but don't forget cystic masses. Younger the patient means, I removed lot of retroperitoneal cyst, large lymphangiomas from the retroperitoneal. So these are few of the comments. Thank you. Thank you.
Thank you, sir.
Thank you.
The next case. Who's presenting the next case?
I'm presenting the next case.
Yeah, requesting everyone to mute except the candidate, and those who are asking questions, then please ask so that we can have a good.
First of all, I'm very sorry for the initial technical issue. Sorry, sir. Very good evening to everybody. My name is Riddhima V. Menon, and I'm hailing from Government Medical College, Thrissur, and I'm here to present a case of a 24-year-old female hailing from Pudutturuthi, Thrissur, finished degree, and comes with the chief complaint of feeling of fullness of abdomen since 2 months. History of presenting illness. Patient was apparently asymptomatic 2 months back when she developed fullness of the abdomen. She had an episode of polymenorrhea and hence visited the gynecologist. She was examined and the gynecologist explained the presence of a mass in the abdomen. After that, she could feel a mass in the abdomen. USG abdomen and MRI abdomen was taken as advised by the gynecologist. There is no history of abdominal pain. No history of vomiting or abdominal distension. There is no history of altered bowel habits. No previous history of trauma to abdomen. No history of swelling of the right lower limb, pain, paresthesias over the lower limbs. No history of fever or night sweats. No history of burning, micturition or hematuria. No history of swellings elsewhere in the body. There is no history of jaundice, cough, breathlessness, or hemoptysis. Patient was evaluated at an outside hospital and referred to Government Medical College, Thrissur. Past history, there is no previous history of diabetes mellitus, hypertension, ischemic heart disease, bronchial asthma, or pulmonary tuberculosis. There is no history of drug intake or prior admissions, no history of radiation therapy received in the past. There is no history of any previous surgery. Personal history, there is no change in the sleep pattern, no change in the appetite, there is no change in bowel or bladder habits, and no addictions. She's a married female, nulliparous, with the menarche attained at the age of 13 with regular 28-day cycles with 4 days of bleeding. Summary, a 24-year-old female with complaints of fullness of abdomen since 2 months with no associated symptoms. She consulted the gynecologist and was advised MRI.
Yeah, sorry.
Yeah, sir.
Could you go to your first slide?
A similar presentation like the other case, isn't it? Otherwise, a symptomatic patient with a fullness of the abdomen. Okay. Sir, Rajesh, sir, you can carry on.
Yeah. Ridhima, okay, so what's your diagnosis by history now?
Sir, the history, patient is only complaining of fullness of abdomen. So it could be a mass arising from...
What's her age? What's her age?
She's 24-year-old female, sir.
Okay, so I mean, Professor Shenoy has just related something
Yes,
about 24-year-old lady.
Pregnancy is ruled out because she had an episode of polymenorrhea and that's why she had come with the complaint. That's the complaint she came with, the gynecologist.
Right. So, what do you think is your diagnosis now?
So from the history alone,
Yes.
I'm not considering any GI pathology since she's not having any associated symptoms.
Right.
It could be a retroperitoneal mass or it could be a adnexal cyst or any limb.
Okay, she's got polymenorrhea with a large fullness of the abdomen, isn't it?
So, but that was only a single episode. The polymenorrhea was only a single episode.
Okay, just one episode.
Just one episode. She saw the first episode and she's married only since 6 months back. So since the first polymenorrhea, she directly came to the gynecologist.
Okay. So now what do you think? 24-year-old lady, history of polymenorrhea with fullness, with a mass in the abdomen.
It could be a gynecological pathology, an ovarian cyst, or a uterine fibroid.
Yeah, I mean, fibroids, uterine fibroid would be, multiple fibroids would be one. Like Professor Khanna just said, what is Meigs syndrome?
Meigs syndrome is ovarian cyst, fibroma of the.
Yeah, and?
Fibroma of the ovary with pseudomyxoma.
And ascites and?
Pseudomyxoma.
No, and ascites and pleural effusion.
Sorry, pleural effusion.
So nothing much in history to come to a diagnosis, except the age and polymenorrhea and fullness of abdomen. So Professor Haridas.
So Ridhima, I would like to ask you if she has come with the ascites as the cause of the fullness. What do you suspect?
Sir, I didn't get you, sir.
In case if this fullness is due to ascites, what are the causes of ascites in this type of patients?
It could be fibroma.
No. I am trying to little deviate you away from the diagnosis which you know. I am just trying to ask you, she is a young patient. She has got ascites. She has come to you first time. So again, ovarian also to be kept in mind.
Fibroma,
Anything else? Any other causes?
It could be a Brenner's tumor,
What is that?
ovarian tumor, Brenner's variety.
Yeah, already mixed syndrome we have discussed, I think. Then anything else? Ascites? Why not tuberculous ascites? I'm asking you a question.
Yes, sir.
No, don't say yes. I'm just asking you, what are the presentations of tuberculous peritonitis?
So patient will have constitutional symptoms along with the ascites, evening rise of temperature, and she might have other GI symptoms. Usually GI symptoms is preceded, like any diarrhea will be there, evening rise of temperature will be there.
No. Just hold on. See, examiners can take you any other question. Is this evening rise of temperature mandatory in all patients?
It's not mandatory, sir. It's not mandatory.
It is not required. What other complaints they may? They may not have diarrhea at all. They may not have diarrhea at all. Unless you have a mucosal lesions, ulcers and all, they will not have diarrhea. It could be a simple exudative ascites. Patient will come with a distension. Of course, more common in children. That's what you should try. Encysted and other things. Granular momentum and all you get. So I just want you to just think, because the question is fullness. Fullness. Right?
Yes.
So why not it is simple obesity? Suppose she has put on weight. I'm just asking you.
Yeah. But in that case, she would not complain about the discomfort as such.
What is the discomfort?
She is telling this, she's having that fullness of the abdomen.
I agree. Upper abdomen or lower abdomen?
Lower abdomen. Lower abdomen.
So when there's a lower abdominal fullness, whatever, what do you suspect? Female patient. So uterine masses, ovarian masses, or some retroperitoneal or something like that, ascites, etc. This is how you should slowly go ahead with your. There's no associated vomiting, nothing, no other features. So these are a few things. Questions?
And now to add on to the tuberculosis thing, don't always say there will be bowel symptoms.
Yes.
The tuberculosis is there.
Yes.
Only one of them is GIT tuberculosis. There is peritoneal tuberculosis. There could be lymph nodular tuberculosis. There will be parenchymal tuberculosis. All this can happen in the abdomen. Okay. So the bleeding and diarrhea and all those things happen only in the GIT tuberculosis, which is most commonly seen in ileocecal junction. Okay. So it's not necessary to have all these symptoms in tuberculosis. They may present with vague complaints, as rightly pointed out. In our setup, though tuberculosis come down drastically, you still have to think about these conditions. Okay, correct. So
here I think we should think of the genitourinary tuberculosis.
Yes,
the patient has got the polymethuria. So we are not thinking the GI tuberculosis here, but the genitourinary tuberculosis.
Why didn't you consider mesenteric cyst?
It is one of the diagnoses after the history. Yes, sir. It's one of the diagnoses.
Fullness below the umbilicus, young patient, no? Young. It's more common in young patient. Yes. Okay, go ahead.
General physical examination. Patient is examined after obtaining consent in a well-lit room. She's conscious, oriented to time, place, and person. Moderately built and nourished. Weight 48 kg. Height 152 centimeter with a BMI of 20.8. ECOG performance score status 0. She's afebrile. Pulse rate of 82 beats per minute. On the right radial artery in supine position. Normal volume and character. Blood pressure of 120/70 millimeter of mercury in the right arm in supine position. Respiratory rate of 13 cycles per minute. She's well hydrated. There is no pallor, icterus, cyanosis, generalized lymphadenopathy, or pedal edema during examination. Abdominal examination. She was examined after obtaining consent in a well-lit room. Abdomen examined in supine position with adequate exposure from nipple to mid-thigh. Inspection. Abdomen was protuberant with the fullness noted over the right iliac fossa and hypogastrium. There's no skin changes seen over it. Umbilicus is central. All regions of the abdomen appear to move correspondingly with respiration. No dilated veins, visible peristalsis or visible pulsations. Hernial orifices were normal on inspection. External genitalia appeared normal. Palpation. Inspectory findings were confirmed. There is no local rise in temperature. A palpable mass noted in the lower abdomen, approximately 10 × 15 centimeter, occupying the right iliac fossa, hypogastrium, umbilical, and a part of the right lumbar region, with extending left to the midline. Mass was well defined with irregular borders. Superior border approximately 1.5 centimeter from the umbilicus. inferior border extending just above the umbilical ligament and pubic symphysis, lateral border 2 centimeter medial to the anterior axillary line on the right side, and medial border 3 centimeter left to the midline. On each position, the mass doesn't fall forward. Mass was hard in consistency with smooth surface with no tenderness on palpation, no movement with respiration and no intrinsic mobility, and the mass becomes less prominent on contraction of the abdominal musculature. No palpable pulsations were noted over the mass, no palpable hepatomegaly or splenomegaly, no expansile cough impulse noted over the hernial orifices. Percussion, no free fluid noted in the abdomen, liver span was 10 centimeter in the right midclavicular line, dull note on percussion over the mass, rest of the abdomen was resonant on percussion, auscultation, no bruit over the mass, normal bowel sounds were heard. For vaginal examination was normal, fornices were free. For rectal examination, normal. Neurological and vascular system assessment of bilateral lower limbs, normal. Systemic examination, respiratory system, normal vesicular breath sounds heard. Bilateral air entry equal, no added sounds. CVS, S1, S2 heard, no abnormalities noted. CNS, no focal neurological deficit. Summary, a 24-year-old female with history of fullness of abdomen since 2 months, having noticed on the right lower side of the abdomen with no associated features. On examination, there was a palpable mass of 10 into 15 centimeter hard with smooth surface, well-defined irregular borders noted in the right iliac fossa, hypogastrium, umbilical, and the right lumbar region.
Ridhima, again, I would have loved it had you qualified whether this lump was intraperitoneal or retroperitoneal.
Sir, I had mentioned the knee chest position in the palpation.
Okay, let's go. Let's see that. What does it say?
Yeah, sir, I mentioned.
Okay, first of all, we'd never put anyone. You can't make a horse out of a human.
It's lateral knee chest position I had put the patient.
No, there's nothing called lateral knee chest or supine knee chest or okay, nothing like that. You can't mention knee chest anywhere. Also, I mean, I just like to tell you in history. I don't know, when we were students, we were taught to always ask for family history or social history in cases of malignancy. I mean, it was a must to see what the family support would be like if the patient was undergoing treatment. But this sadly is missing in most of the students these days. Maybe I think we've become very patient-centric rather than family-centric. But I would love, if you're dealing with a patient, especially of malignancy, we must know whether the patient can have social support, family support, and can continue with the medication. Okay?
Okay.
Also, one more point, Ritima, the knee, chest, or knee, elbow, whatever position you put the patient in, usually it is significant in central abdominal lumps. Okay, lateral side abdominal lumps. They may know what are the characteristics of falling forward. One, it may become more prominent. And number two, the transmitted pulsation may become absent. So, to get a transmitted pulsation, it has to be centrally placed abdomen. So, laterally placed masses, knee, chest, knee, elbow, or other than that, lateral position will be more ideal to check whether it's falling forward or not. Okay, not the knee, elbow position. Okay.
Can we go to the inspection slide, Doctor? Yeah. So one or two things. I just want to ask you question for my sake. Why did you examine from nipple to thigh? Very fundamental question. Looks simple, but answer this question.
So usually the means extension of the liver span has to also be examined, and that starts from the upper part. And lowerly, we have to examine for the hernial orifices to complete the abdominal examination.
You said thigh, no?
Mid thigh.
Yeah, mid thigh. You said. Why mid thigh?
So the hernial orifices have to be examined.
Mid thigh. What hernial orifice will come? Mid thigh. I just want to ask you one or two things important here. The idea of telling is more than liver span. We should not miss a breast mass in a female patient, especially with abdominal mass, especially for the liver, Krukenberg, etc. Okay, that's the purpose. This is a young patient. That's why you need to examine the breast. And in males, you give an explanation of this liver span, whatever you have said. The Thigh means basically to do any large hernias. That is the reason. And testicular tumor. That is the reason. Especially in a males, it's important. In a female patient, you can maximum is a femoral hernia. That's all. You don't find a very large hernia in a female indirect going into the middle of the thigh and a giant hernia like that. It happens only in a males. I just want you to understand this. The philosophy or science behind the clinical examination. We have written there one important, no skin changes. What is the skin changes?
Usually with large masses, if there could be any dilate means skin durations or skin changes, like
you will
redness
not,
of the
you will
skin in
not,
case
you
of
will not get any change.
pathology.
You have seen the last presentation of a 35 into 20 centimeter mass. Like a, you will not find that. What did you have in mind? That's what I wanted
Any
to know.
inflammatory pathology or any abscess could have been having any skin changes.
Abscess. You are talking about abdominal mass and abscess. See, this is the problems of you people. This should not compare to a neck swelling, because same thing you are done in the palpation. You are written no local rise of temperature. Somewhere you have mentioned that. See, you don't expect that in an intra-abdominal masses like this. You understand? I will have been happy if you say there are no Kefle spots. You understand?
Yes,
why it is important?
To rule out neurofibromatosis.
So your diagnosis, if you are going in that direction, yes. So it's possibly you generalize in general examination, you find some skin changes like you would have thought in that direction, rather than giving this way presentation. The rest of the things, okay, all quadrant regions move correspondingly, all that you are no dilated veins, etc., etc. Again, external genitalia. What is that you are interested in female patient?
Sir, in female patients, usually the external genitalia, because of males, it is significant when it comes to such a large mass to look for scrotal edema. As for the completion, I've kept it.
Completion. Any other thing? You have got a very hard mass here in the pelvis, or not pelvis truly. You said right iliac fossa, hypogastrium. So if you are asked this question, what you would have probably told? I don't want to miss a hernia, or maybe secondary vulval varicosities. A large pelvic masses can give rise to retroperitoneal tumor. Hemangiopericytoma, sarcomas, and all common in females can give rise to this kind of a picture. That is the importance. See, you should know why you are examining. That is what I would like to impress. Okay. Thank you. Sir, please go ahead.
What is the importance? Did you examine the spine of this patient?
Yes, sir.
What is the importance?
She didn't have any tenderness or any fullness over the paraspinal area. Usually, any pathology which we could rule out is any paragangliomas could have, or patient, in those cases, patient will present with other symptomatology of neural deficits or pain. Otherwise, any metastasis could be ruled out with to the spine.
Okay, what is the consistency of this mass?
Hard mass, sir.
Hard mass. Okay. Suppose a little more soft. Anything else you would have been interested in the spine? Yeah, cold abscess. Yeah, it is in the right iliac fossa extending from the lumbar region. Can this be a abscess? Maybe, yeah. Completion sake, you have to see the spine. Maybe it's a psoas. Psoas will be a little more low down, but definitely you need to think of it's not an ideal position for psoas abscess. It's a hard mass anyway. It's not cannot be psoas abscess. So think about those things. Spine is very important part of the abdominal examination. So you have to think about that also. Okay. Right. Any other examination you have to describe now? Finished or one more? Show me the picture again. That picture inspection. It's rightly pointed out by Rajagopal Senai sir, because you have to expose from the mid chest to the mid thigh, because abdomen is divided into various parts. You know that this is something called thoracabdomen, which is from the nipple level to the costal margin, and from the costal margin to pubic area is called abdomen, anterior abdomen, and then flanks. Flanks are between the anterior axillary line, posterior axillary line, right from the sixth rib to the iliac crest. That area is called flanks. Okay. Then there is back. Don't forget to examine the back of the abdomen. Many students do examine only the anterior part of the abdomen. Abdomen is not only the anterior part of the abdomen. It's a cylinder. Abdomen is a cylinder. Posterolateral part of the abdomen is also abdomen. So you have to turn the patient or make the patient stand, sit, whatever, or turn the patient around, see the back of the abdomen, flanks of the abdomen. They are also part of the abdomen. So don't forget to examine those areas. Okay. Yeah. Continue with your. So what is the diagnosis at this point? We already discussed many other things in the last class case. So most of the things are similar. Did you palpate again here again? Did you palpate bimanually? Bimanual palpable? Did you mention about
Sir, in this case, there is only a slight extension into the right lumbar region. So it was, even though when I tried anteriorly, it was palpable, with the anterior hand, it was palpable more.
So it's palpable bimanually?
Yes, sir.
Not ballotable?
Not ballotable.
Okay. So what is your clinical impression? Carry on.
1 minute. Have you done the percussion and what is the findings in this?
The percussion, it was dull note on the mass, sir.
Because, the mass. So what is the inference of that?
So it's already, I mean, since it's a hard mass, it could be, if that's maybe one of the reasons why there's a dull note on that. And usually, if there is a band of resonance over it, that means the colon is being pushed anteriorly. But here we have getting a dull note directly on the mass with no signs of resonance.
So generally, when we talk about retroperitoneal masses as they come up, no, pushing the intestines
colon anterior.
So not necessarily bring the word colon now. Yes, it is in the right iliac fossa, no doubt. So some kind of a resonant note, but in your case, it is totally dull. That's what you are written. Rest of the abdomen was resonant, like any other case. Why did you mention specifically no bruit? Anything you had in mind, or is it completion sake? I would have appreciated if auscultation normal. That's enough. Unnecessarily, you like what bruise you can get probably in that area. They may ask you this question because you raised this issue.
Unless it is a renal swelling, you probably won't get a bruise. Okay.
Are you suspecting any aneurysmal dilatation of the common iliac artery or anything like that in the right iliac fossa here? No.
No, sir. No, sir.
You said hard. You said everything is like that. Auscultation, normal bowel sounds heard. That's enough. That's what you are auscultating. It's not like any other hepatocellular carcinoma or a renal cell carcinoma or something like that you want to auscultate. Right. Okay. So, like at the last time we asked, I think supraclavicular node, all that you mentioned, I suppose.
Sir, yes, sir. In general examination, I had mentioned. Sir.
No. Supraclavicular node should not come in general examination. Okay. You should make the patient sit. See, all the time your patient is lying down. You have to examine the patient sitting position. You go behind, gently palpate, carefully palpate. If you make the patient lie down, you may miss also. Huh? So it should be a separate examination. You have to give importance to that, right?
Summary. 24-year-old female with history of fullness of abdomen since 2 months, having noticed in the right lower side of the abdomen with no associated features. On examination, there was a palpable mass of 10 into 15 centimeter hard mass with smooth surface, irregular borders noted in the right iliac fossa, hypogastrium, umbilical region, and extending to the right lumbar region. With this, my probable diagnosis is retroperitoneal tumor, probably malignant in nature.
Sir, I think it's actually my case. So I think Rajagopal sir will take over. I think I don't want to ask many questions, sir.
So yeah, one question to you. Why not? It's a lymph nodal mass.
Sir, first of all, the surface is smooth. There is no nodularity. Second, there is no when there is no constitutional symptoms in the patient and no other lymphadenopathy is not seen anywhere else, any other lymph nodes.
You are written there hard, correct?
Yes, sir.
You are written there hard. Then you are also written irregular, and mobility is.
So no intrinsic mobility.
No mobility. So keeping that in mind, I asked you a question. Why did you tell no constitutional symptoms?
Like fever, night sweats are not there in this patient.
No, what
Suspecting a lymphoma.
So you are talking about less likely to be lymphoma. That's what you are trying to say.
Yes.
Iliac node mass. Right? That's what you are trying to say. So hard nodes are typical get in which condition? Your hard fixed ureter.
Metastatic nodes could be.
So my question to you is iliac nodes, if there is a metastasis, I'm just trying to ask you a little different way. What are the primary you will suspect?
So males, you could suspect a testicular.
You get iliac nodes. See, this is what examiner will ask you in the university, because we know you have seen that CT scan and diagnose. Testis drains to iliac nodes. Is it?
No, it's not common. It's usually to the
then
pancreatic nodes, and then.
So I think you need to read a little more. Tell me now the sites of drainage, the iliac nodes. Just tell me. If somebody comes with iliac node enlargement, iliac lymph nodes, iliac, what are the things you suspect, if at all? Drainage. You got stuck now.
Which are the areas you can drain to iliac nodes?
You told lymphoma. Lymphoma one we have considered. Okay, consider that ruled out.
Pelvis, lower limb.
Yes.
Cervical pathology.
You have to tell, no?
Cervical pathology, malignancy.
Lower limb.
Anything.
Melanomas.
Don't forget that. Okay. Yes. So what about the? See, somebody has pointed out bladder. Somebody has pointed out. So pelvic pathology, right? Female patient, no? Female.
Yes,
so, I'm not trying to say your patient has got uterine carcinoma or something like that, but I just want you to understand what we are talking. If there's iliac nodes are involved, what are the primary? That's what I asked. Okay, right. So your patient has got a lymph mass, according to you, it's a retroperitoneal tumor, correct? Right? Any differential diagnosis? We have ruled out lymph nodal mass. Agreed. Next. You never suspect any intestinal pathology here, right, iliac fossa?
Sir, patient does not have any GI symptoms in patient. Any mucosal lesions will have symptoms associated with like melena, or the patient might present with signs of intestinal obstruction, which is not there in this patient.
Which tumors? This also we had discussed just last. Can present as a nodular mass, but with mobility. They need not have obstruction. They need not have bleeding, correct? Which intestinal tumors?
Mesenteric?
No. Intestinal tumor. We discussed in the last case, no?
Which need not have bleeding. It may ulcerate and cause bleeding later.
Necessarily from mucosal surface, from other layer of the intestine.
We have gist
can answer. Yes, gist can present.
What does gist means?
Gastrointestinal stromal tumors.
This is the common site.
Site is stomach.
Huh?
Stomach.
Stomach is the common site. Not that you can't get in the right. You can get. It can be nodular mass. It need not have ulceration bleeding. It can, but this kind of a hardness and completely restricted mobility is less likely. So you have to get ready to face all these questions. If it is a bowel mass, not from the lumen, means no symptoms. This is one of the possibilities. So retroperitoneal structures, soft tissues, then comes the lymph nodes, and then come this. I think TB spine. I think Dr. Haridas has already asked you examination of the spine. Sorry, Rajiv sir, and any other questions, sir? Khanna sir.
I'll add on to this, sir.
Yeah, please.
The right iliac fossa mass from the right ascending colon and cecum, you need not get any symptoms sometimes. You may get a large mass without obstruction, without bleeding, without any symptom. Actually, the patient may come with vague symptoms like weakness, anemia, and then you find out. I'm not saying this is a right iliac fossa mass, is a colonic mass, But don't say because of no bleeding or bowel symptoms, it cannot be from the right iliac fossa, the cecum and ascending colon. You can still get it. It can be okay. This may not be. This is a hard fixed mass. It may not be from the colon. Rajesh sir, is there?
Okay, should we now move to the management of this patient? So, okay, Ridhima. So what was your primary diagnosis?
Retroperitoneal tumor, probably malignancy.
Oh, okay. So now, how will you go about managing this patient?
So I would first take the
Okay,
USG
before that, what are the points in favor of retroperitoneal malignant tumor?
Sir, the mass is not presenting with, starting from the history of symptomatology, the mass is not presenting with any symptoms, and it's a large mass with no mobility.
Okay.
And there's no bowel associated constitutional symptoms.
Like you said no intra-abdominal organs symptoms. What else? Have you been able to demonstrate that's retroperitoneal?
Sir, in that chest, in the left lateral position, as I said, but then.
Does it fall or doesn't fall?
It does not fall forward.
Okay, so we go for it. We take it. So that's another reason. What else?
In this patient, PV examination was normal.
Because she's 24. Why do you think it's malignant?
So it is only a 2 months history. So drastic. It's not a slow growing, it's a fast.
Rapidly progressing tumor.
Hence, I'm suspecting in terms of malignancy.
Okay.
Plus, it's a hard mass. Pathology is ruled out in this patient.
Okay, so it's a retroperitoneal mass of 2 months, which is increased in size. So such a large one is hard. So you think, okay, fine. So
can
how
it be
do you?
Renal mass? Okay, you said it in the lumbar iliac fossa. Can it be a renal mass?
So, no, it cannot be a renal mass. It's not ballotable, first thing. And there is no associated symptomatology like hematuria or burn in this patient.
Okay, what renal mass malignancy, if it was a renal mass, would you think of?
Hydronephrosis can be present.
Malignancy. What
hard mass?
Hard mass.
RCC.
Okay. So in how much percentage of RCC do you get hematuria?
Sir, pain is the most common symptom actually in RCC.
No, look, my question is in how much percentage do you get hematuria?
Not sure, sir.
About 1/3, just 30%. So it's not very common, right? So you can't see symptomology of hematuria, right?
Okay.
Right.
So your diagnosis is retroperitoneal sarcoma. That's it. There's nothing else.
Retroperitoneal soft tissue, yes.
Soft tissue swelling. Okay, how will you confirm your diagnosis?
Sir, investigation-wise, I would first like to take a USG as an extension of my clinical findings. Along with that, it gives me it tells me about the origin of the organ of origin, as well as if any ascites is present. Investigation of choice is in CT abdomen. In this, we can confirm the organ of origin as well as the vascular associated attachment or increasement to the vascular structures, any metastasis, or any lymphadenopathy in these patients, in this patient.
Okay. And also metastasis you can study. Okay. So have you done anything?
Sir, this patient is actually being worked up. CT abdomen is only given to the patient. It's still pending.
Okay, sorry, Ridhima. If you think it's a retroperitoneal tumor, as a surgeon, what will come to your mind? I mean, how will you be very comfortable with it? What is the reason why people are surgeons are very skeptic about retroperitoneal tumors? What is so important about it?
Sir, compression over the vessels, since it's a retroperitoneal.
Look, compression can be then intraperitoneal also. suppose you're a surgeon and you're given the choice of operating on a retroperitoneal tumor or an intraperitoneal tumor. Which will you prefer, and why?
So actually, intraperitoneal, retroperitoneal, the approach, first of all, we have to go through the transabdominal approach has to be done, and mobilization of the whole of the colon has to be done in these patients.
So retroperitoneal tumors, first of all, they present late, so they are generally widespread, right?
Yes.
Secondly, then close relationship with very vital organs, structures, which cannot be cannot be maybe sacrificed. So as a surgeon, these are the things which will come into my mind when I make a diagnosis of retroperitoneal tumor.
You say CCT. What are the points other than the local origin, what are the structures you got to look for in this patient, in this particular case?
In this case, I'll have to look for the ureter and the iliac vessels. Is it in the right iliac fossa?
What about kidney? We had a doubt about the kidney origin, no? You can confirm whether it's attached to the kidney or is originating from the kidney. Okay. All this you have to also the metastasis, ascites. What is the most common site of metastasis in retroperitoneal sarcomas?
So liver is the most common site of metastasis.
What is the most common site of metastasis in limb sarcomas?
Lung. Lung is the most common site.
So that is the dictum. The limbs go to the lung, and the abdomen and the retroperitoneal go to the liver. Okay. Second station is always lung, but the most common is the liver. So you can assess the liver by CCT or MRI. CCT is better. Okay. So you can assess it, and then you can probably see the liver, with the kidneys, the ureters, the iliac vessels. All these you can assess by CCT. Okay. Yeah. Then what will you do? Okay, CCT. After CCT, how will you proceed? What is the next step? Already we discussed most of it in the last case. You can just repeat it.
So the treatment of choice for any retroperitoneal tumor is surgery. In the CCT, if we find that the lesion is unresectable, then we would like to take up the patient for pre-op radiation.
Ridhima, I have one or two questions now before you proceed. One is, if it is a kidney mass, is it possible?
What is possible?
This mass. Why it is not possible?
In the examination findings, as I said, it was not palatable, the masses.
Can you get a renal mass in the right iliac fossa?
If it is not ascended, you can get a renal mass in the right iliac fossa.
Okay. So just for you to understand, in men, of course, we also say undescended testis and unascended kidney. No, this is how you should write. What is the most common pathology you get in a unascended kidney? Definitely not malignancy.
The horseshoe kidney will be seen in this patient.
No. Unascended. You mentioned actually hydronephrosis. Ureteric angulation can happen and you get a hydronephrosis. Now, what are the concerns which Rajiv sir was asking you? Especially fixed mass in the right iliac fossa. No? It's a fixed mass.
Yes.
So what do you think structures which you are little bit worried now, scared when you are operating on this patient?
Sir, I'll be worried about the ureter in these patients and iliac vessels.
So between the ureter and iliac vessels, which one you are more worried?
Sir, iliac vessels.
Obviously. So how do you identify the ureter? Before surgery, can you do something else?
Stenting can be done in these patients.
And
in intra-op, if the patient has to be, if the ureter has to be identified, there's something called illuminant stent. Ureteric stents are used, or dye can be used. Endocyanin dye can be used.
At surgery, how do you identify the ureter? You have started mobilizing the tumor. You have started mobilizing. Colon has been already separated, let us say, by the tumor. So,
if in case of illuminant ureteric stent, you can use a fiber optic line.
No. We're not talking about illuminant.
No stent.
We don't have that facility. So
DJ stenting can be done in these patients.
No. At surgery, how do you identify ureter? Let us say stenting has not been done. She's all the time telling you feel the stent. No.
crossing of the vessel, right? The vessels can be checked where the crossover, that's where the ureter is usually
Which vessel?
found.
Which vessel? Where?
Right external iliac, right at the pelvic brim.
Okay, where at the pelvic rim? Very specific.
Once
Which vessels are going to is the ureter going to cross? At what point?
External iliac vessels are crossed at
At the bifurcation
of the common iliac. Of the common iliac into the right and left internally. External and internal iliac.
Right. So just at that point, you'll always find the ureter. What else is very characteristic of ureter?
anything else? Yeah, that's important.
The peristaltic movement of the ureter can be seen.
Okay, what else? Anything for blood supply?
Somebody has.
Someone has already answered it. Okay. Okay.
So
I think people should refrain from answering. This is an examination for Ridhima rather than you guys.
So whenever right hemicolectomy is being done, you see all these points which have been highlighted now. You will come across this. For some reason, you have cut the ureter. What will happen? Urine will come out. Suture it. Okay, we'll talk about it. Yes, sir. Please go ahead, sir.
Okay, Ridhima, you said the CT scan is diagnostic. It will tell you about the organ of origin, will it? So I'll just ask you a question. Suppose the mass is very large. What is the phantom sign in the CT?
If the organ is, if the mass is really large, the organ cannot be delineated. From a small organ, if such a large mass is coming, the organ cannot be delineated. That's phantom organ.
Right. So the mass is so large that it covers the whole of the organ of origin.
What is primary retroperitoneal sarcoma and secondary retroperitoneal sarcoma? Is this a primary or secondary?
It's a primary. So secondary is when it is arising from the retroperitoneal organs. Primary is when it is arising from the retroperitoneal fat, nerves, etc.
You think it's a primary retroperitoneal? It's not arising from any particular organ, is it? Okay. Right. So you do the CT, you assess the ureter, you assess the iliac vessels. There's nothing. Okay. So it's not. Suppose infiltrating on one of these vessels or one of these structures. What will be your next line of action?
In that case, we will go with radiation therapy. These patients. Surgery, once it starts infiltrating the vessels, it becomes inoperable.
Why you want to go radiation upfront, or why can't you do a partial resection later, adjuvant radiation, which is better?
The pre-op radiation is better, sir, because in cases of retroperitoneal tumors, the tumors are usually large, as we mentioned, and so they push out the bowels to the periphery, and hence, in case of pre-op radiations, they will in turn be protective for the bowels. At the same time, post-procedure, when we give the radiation, the tumor bed will be covered with the normal bowel. The bowel will come back to its normal position. So they will be exposed to the radiation. At the same time, there will be post-radiation fibers.
Initially, if you do preoperative radiation, the blood supply is intact, How does the radiation work?
The vascularity of the tumor is being reduced.
No. They usually work by releasing the oxygen-free radicals. For that, you need oxygen. For that, you need good vascularity. Okay, so always preoperatively, there will be good vascularity. So it's better to, radiation will work better preoperatively. It will reduce the size, and bowels will be protected also. So you can give preoperative radiation, slightly better, but if you've done a surgery, you can always already spilled or residual tumor, you can always do. What precaution will you take? Suppose you do surgery up front.
Sir, may I intervene? Ridhima, before you go in for surgery, would you like to do get a tissue diagnosis?
Usually in retroperitoneal tumors, tissue diagnosis is not done, but it can be done in cases of unresectable tumors, or when we are to rule out lymphoma, or in cases of metastasis, and in cases of recurrences.
Okay. And what about the size of the tumor? Does it affect the prognosis?
Yes, large tumors with the histopathological grading both affect the prognosis of the disease.
No, tumor size has no prognostic value, unlike soft tissue sarcomas in the limbs, right? Why? Because they are very large lesions usually with rarely with nets, right? So here there is no, because they present late, and large tumors, the size of the tumor is not very important. It's the grade of the tumor and the kind of tumor rather than size. Okay.
What surgery you do? I think we'll go to already.
Right. Okay.
What surgery are you going to do?
So excision of the tumor.
What is the treatment of peripheral soft tissue sarcomas? Peripheral. Wide local excision. Why can't we? Can you do wide local excision in the retroperitoneal?
So in those, we'll have to see for the other adjacent organ involvement. Along with that, we'll have to remove.
That is the question. Will you do an elective wide resection of the adjacent organs, normally looking wide organs or not, for the sake of wide excision?
We need to attain an R0 resection, but if the organ can be spared,
No, Reddy, okay, before we come there, is there a difference between surgery for a low-grade tumor and a high-grade tumor?
So in high-grade tumor, we try to remove the entire bulk of the tumor, because in those cases,
Very good. So we don't do debulking in high-grade tumors.
Yes, sir.
But you can do that in well-differentiated. Okay. Good. Right, you can go on with source.
My point is, there is no advantage in removing that adjacent organ if they're seemingly normal. Okay, if they're involved, only you remove. For the sake of getting a wide resection, you don't remove the adjacent organs. Okay, so all you need to do is the removal of the tumor with the normal other adjacent tissues. That's fine, better, good enough, because there's no added advantage in removing normal adjacent organs for the sake of wide resection. Okay. Yeah.
Okay, so you said what is R0, what is R1, and what is R2?
R0 is when there is microscopic as well as macroscopic clearance. R1 is when there is macroscopic clearance but no microscopic clearance. R2 is when both are not cleared. I mean, both macroscopic and microscopic clearance is not.
Right, very good, very good.
Okay.
So suppose you've done an R's, probably an R1 or an R2, right? So what is the chance of recurrence?
Chances of recurrence is 20%, sir, in intra-abdominal.
It's almost 40 to 50%, 30 to 40%.
So what will you do? Section, what is the chance of recurrence? Suppose you done R0 liposarcoma, R0 resection.
Chances of recurrence are low, sir.
Even in R0, there's a very high chance of recurrence. So R1, R2 is definitely 40%. Okay, more than that.
It's very high.
Very high.
So what will you do to prevent this?
Most of radiation can be given, adjunct chemo could be given.
So that's why most of the retroperitoneal tumors require radiation, RT. Unlike intra-abdominal tumors.
What precaution will you do? Will you do any preparation for giving radiation at the time of surgery?
I don't get to say.
Will you do any preparation for postoperative radiation while you do excision or wide excision of the tumor?
I said we'll clip the area around in order to find the tumor margin.
If you know,
the bowel can be covered with the omentum.
Bowel can be shifted out if it's possible. Bowel can be shifted out because in bowel injury is the main problem of abdominal radiation. Isn't it? Bowel can be transplaced. I don't know. It's not easy to do that, but and also the area can be marked where exactly we found it's very close to the margin. That area can be marked with clips so that you can radiate that particular area in particular. Okay. What is the role of chemotherapy? You said chemotherapy. What are the drugs you can use?
Okay, first before that, sir, sorry, Ridhima.
Oh yeah.
What are the tumors which are sensitive to chemotherapy? Which retroperitoneal tumors are sensitive to?
spindle cell and round cell are sensitive. Synovial. Not sure. Two of them are sensitive. Not sure.
Okay. So right, round cell is one.
Round cell is
Round cell liposarcoma is one. Others? Leiomyo?
Not sure, sir.
Angio? Okay, these are the ones. Of course, the most chemosensitive is synovial. Happens in the limbs. Okay.
Do you know any immunotherapy, any drugs used in any particular tumors?
Chemotherapy, drugs
No,
used
no
are
chemotherapy, immunotherapy or immunotherapy or monoclonal antibody therapy.
tyrosine kinase inhibitors can be used.
Huh?
Tyrosine kinase inhibitors.
Yeah, tyrosine kinase inhibitors are used in some. Angiosarcoma, what is used?
EGF inhibitors.
Growth factor or what do you call it? Bevacizumab is used.
Bevacizumab is
Okay. What is used in GIST? They're all sarcomas, no? What is used in GIST? Imatinib, yes, imatinib. All this can be used. There's a role. So that is radiation. Chemotherapy is no limited role in a very desperate situations. You can use chemotherapy. It's not very chemosensitive, but still used chemotherapy is used. Even in Western, they used to downsize the tumor. They keep chemotherapy also. Okay, so maybe some use is there, but no, though not very chemosensitive. Radiation and all these immunotherapy and monoclonal antibodies are used in various tumors. Okay. Right.
Okay. So you've done the treatment. How will you follow up the patient?
Patient is followed 6 monthly for the first 3 years.
Okay, 3 to 6 months for every 2 years. And how do you follow up? What do you do when they
Patients
come?
followed with USG abdomen, and if grossly symptomatic, CT can also be taken.
It is always CCT. Always CCT. Okay. Right. Now there are certain complications of chemotherapy. One is called tumor flare. Have you heard of it?
Yes.
Right. Tumor flare is a sudden increase in size of the lesion if you want to give that. Right. Okay.
One follow-up. Suppose the tumor, there's a recurrence tumor. Tumor is recurring. How will you treat that? Is there any protocol for treating with depending on the rapidity or the rate of growth, anything like that? You will depend on that and you will change your management?
In case of recurrence, if the tumor is resectable, we go for resection. Otherwise, a boost radiotherapy can be given in this patient.
What decides? What is the decision? What makes you take the decision? Is there anything related to the rate of growth or anything like that? Is it given in the books?
Sir, anything
rate of growth. It's a rapidly growing tumor. That is more than what they say is more than 1 centimeter per month. That's a rapidly increasing tumor. Surgery has limited role. You can probably go for chemotherapy and radiation. Okay. A slowly growing tumor, very less than 0.9 centimeter per month. This figure is given in the standard textbook. So slow growing tumor, you can think about the re-excision. Okay. That's what. Okay. So on follow-up, if there's a recurrence, you can. So there is a role. What is the role of FNAC? Is there you always mentioned TrueCut and all the things. Is there any role for FNAC?
No role for FNAC, sir. In these patients, the tumor differentiation cannot be done.
No, this is a role.
You can't say that there's no role.
No, you can't say no role because there is a role. Recurrence. I told you the recurrence or a metastasis.
Secondaries can be if FNAC can be done from the secondaries.
Even not only that. Now certain articles are saying with the FNAC you can even do the IHC, karyotyping.
So ultrasound guided or CT guided FNAC can be done.
Yes. We do all the IHC, karyotyping, everything. You can do even with FNAC, they're saying. So FNAC is having a role. But definitely, but it's not well accepted. Only for recurrence and metastasis, it's accepted.
Very large tumors.
Yes. Primary tumor always TrueCut is a better investigation for histopathology.
Have you heard of retinoscopy?
I said, sir,
and retroperitoneal.
Those it's a minimally invasive procedure, sir. And it's usually done in cases of adrenal tumor excision and pancreatic debridement.
Well, it's basically it's most sensitive for lymphomas, right? For lymphomas and METs, right?
Okay, I think.
Okay, I think
We will wind up, sir.
Okay, can you tell me the prognostic factors? Last question before we wind up.
The histopathological
Right.
prognostic factors is one, and then the resection, either resection is attained or not.
Okay, grade, location, adjacent organ involvement,
Adjacent organ involvement
and
vascular structure.
type of margin left behind.
As it
R1.
is.
Okay.
What are the factors we consider in grading this soft tissue sarcoma?
Grade is based on tumor necrosis, mitosis, and differentiation.
Okay, yes. Based on this, score is there. If it's more for 7 and 8, high grade, isn't it? Okay.
Yes, high grade, 6 to 8.
Okay, Ridhima, very good. I'm quite impressed with you.
Well done. Nicely
Well
done.
done. Very good.
Sir, Rajagopal sir, final comments.
Nothing, sir. I just want to ask her that in your patient, would you like to straight away go and operate, or would you like to do a biopsy? Here, you said everything. You said fixed.
Yes.
Correct. According to it, there is not even 1 millimeter mobility. I have not examined, but based on your finding. So, at least you have some CT film of this patient.
Sir, CT is not taken. She's still worked up. The patient is still being worked up, sir.
So why did I ask the question? Because clinically you said fixed. So if it is an
undissectable tumor in those patients.
Suppose a portion of the ureter is infiltrated, what will you do at surgery? Iliacs are free. So you have to try make an attempt to remove. Retroperitoneal sarcomas are usually not chemosensitive. No. So radiation definitely yes. So what will you do? What will you do? One segment, the ureter.
We will not. We will remove the tumor, but not the one attached to the ureter.
It's already touched. You are scared to touch the ureter or injure the ureter.
It's forcing you to cut the ureter now.
You have to remove, because this is remember, young patient. You can't afford to. I gave a clue that it is infiltrating ureter, but not iliac vessels, right?
Can he remove her kidneys if involved?
Sir,
no, I'm asking you.
If the renal safety is there, then yes, one side kidney. If there is infiltration to the kidney and the opposite kidney is working, then yes.
Yes. See, you may even remove the kidney if the outside kidney is not there. Then you have to go in for a renal transplant.
Please remember your patient.
It's always for oncological clearance. You should remember. Okay, always oncological clearance is the most important thing. Okay?
Small segment of 1 to 2 centimeter you can mobilize and join. Yeah. If it is more than 4 centimeter lower end, you may have to raise the bladder flap. Or if it is large segment is gone, it's mentioned in the. I have no experience of that. Even one ureter, you can anastomose to another ureter. You understand?
Cross anastomosis.
I may be wrong, because nowadays I have no idea. But that's ureterostomy. Earlier, one case we have done long back. You understand, no? What we are talking. So it is not a contraindication. That's what I would like to mention. So, sir, I think we can probably stop now.
Right. Okay, sir.
Yes. Dr. Kanak is there. Dr. Kanak. Shall we conclude?
Yes, sir.
Can I get Dr. sir?
I think he may be traveling.
Emma, do you want to ask any questions? Any doubts?
Emma, you want to?
No, sir.
No, yes,
Karunakaran sir is there. Sir, anything from your side?
No, sir. No, sir.
Okay, so that's call it.
Okay, sir.
Thank you, sir.
Thank you, Ridhima.
Well done.
Well done. Good night, everyone.
Okay, good night, sir. Good night, all.
Good night. Thank you.
Good night, everyone.
Good night, sir.